Hi, my name is Dr. Zev Wainberg. I'm a professor of medicine and co-director of the GI Oncology program at UCLA School of Medicine in Los Angeles, California. So the primary risk factors for esophagogastric cancer in the United States have been noticeable in recent years because we are seeing some epidemiologic changes in this disease. We have seen in the United States actually a decrease in several esophageal cancer varieties, such as squamous cell carcinoma, and even body of the stomach tumor has decreased in incidence in the United States and the Western world. But we are seeing increases in gastroesophageal junction adenocarcinoma, both in the United States and the rest of the Western world. It's still a fairly uncommon malignancy, but compared to 25 years ago, we are seeing a significantly proportional increase in the incidence of that cancer. And this is felt to reflect fundamental changes of risk factors. And what are those? Because gastroesophageal junction adenocarcinoma involves changes in the distal esophagus, which include dysplasia and the precursor to that, often Barrett's esophagus. What we're talking about is fundamental increases in esophagitis. And the hypothesis behind why that's increasing in the United States is due to levels of increased obesity. And obesity itself is a risk factor for gastroesophageal reflux disease. Gastroesophageal reflux disease can lead to Barrett's esophagus and dysplasia. Barrett's esophagus and dysplasia can lead to cancer. So on a society level, we do think that some of the demographic changes that we're seeing in the incidence of this disease in the Western world are linked to increases in obesity. There are a number of other hypotheses related to what we eat and what we consume as being risk factors for this disease. But the most prevalent hypothesis is that fundamental increases in body mass index or obesity have led chronically to increased risks of gastroesophageal reflux disease and subsequently over a long-term course cancer. And that has important implications, obviously, for us as a society. Number one, it's yet another reason for us to try to help with reducing obesity rates in this country. Number two, it does lend the discussion whether certain characteristics of patients or certain patients should be at higher risk of these diseases where screening categories are applied, and many other things to think about. It's a very interesting disease epidemiologically, where we've seen in the last 20, 30 years a fundamental decrease in the risk of squamous cell carcinoma, which was linked to smoking and alcohol abuse. And while still a problem in the Western world, the incidence of that cancer has gone down dramatically over the last 30 years, thanks to decreases in tobacco use. And while still the biggest, most common form of esophagus cancer in the Eastern world, we're seeing it much less so in the Western world. But simultaneously with that, we ourselves now are seeing this more of an increase in gastroesophageal junction adenocarcinoma. And that's typically in white Caucasian men, which is the most common area where we do see that, which is obviously also associated perhaps with obesity and risks of Barrett's esophagus. And, and this is representing more and more of our population over the last 10 or 15 years, including many patients diagnosed with stage 4 cancer. So we really are trying to understand this phenomenon a lot better, although it seems clear that over the last 10 years of research, aside from perhaps melanoma, gastroesophageal adenocarcinoma has the greatest generation-to-generation change in terms of percentage of incidence. Doesn't mean the largest numbers, of course, but percentage from being a relatively low thing 25, 30 years ago to now being a much more common malignancy.